Good evening, ladies and gentlemen. It's my great pleasure to introduce Dr. Kalpesh Gandhi for the topic significance of prognostic cardiac markers, HS-CRP and homocysteine. He is Associate Fellow of Industrial Health in 2010, experience in running standalone laboratory. And he's also an annual assessor since 2009 and CAP accredited since 2011. Here, Dr. Gandhi, please.
Thank you, Dr. Ghosh. So this is the take-home message. First, I flipped these slides. So CRP is essentially the same as what we are analyzing, but with the high sensitive, which increases the sensitivity of that particular analysis. But there is a lot of buzz is around since 2000, I suppose 17, 18, CRP monomer will go to that. It is not the same as the HS-CRP or CRP. The analytical method which we use for CRP must have the traceability of CRM 470, which was first assigned way back in 1990s, probably 93, if I am not mistaking the year. And then again reassigned by NIST. First assignment was done in collaboration with IFCC, European Commission and US FDA along with the CAP. So we are using a lot of terminology since morning, that is prognostic marker, monitoring marker, predictive marker, risk marker. Right now CRP has established as prognostic marker, susceptibility risk marker and predictive marker in association with the other biomarkers for cardiovascular disease. We will go to the categorization of the biomarker in subsequent slide, where FDA has clear-cut given the subcategories or categories of the biomarkers and how you should, to harmonize the usage of this biomarker, how you should use the terminology of that biomarker. And the last thing is that there are ample of possibilities that the CRP or MCRP specifically can be used as response biomarker, which is pharmacodynamic marker. So there are a lot of research are going on drug development in terms of drug development. Let's go with the first slide. This is actually the last slide of CRP. So let's go with the definition of biomarker. So biomarker is, this definition is essentially given from for US FDA whenever somebody has applied particular parameter to has the biomarker capability. It should have a defined characteristic that is objectively measured as an indicator of normal biological process, pathologic process, response to exposure or intervention that includes the environment as well as the therapeutic intervention also. So essentially the biomarker is to aid the understanding of one or more the prediction of disease, its causes, diagnosis and response to the intervention. So these are the 7 categories which was given by the US FDA. So all the essentially biomarker could be anything, not only the serum or blood biomarker. Radiology, radio imaging is also a biomarker. Blood pressure is again a biomarker. So it could be a histopathological, radiological, molecular, all. The response biomarker is again divided into 2 categories. That is the, one is the pharmacodynamic biomarker and the surrogate endpoint biomarker. So what is the diagnostic biomarker? That used to detect to confirm presence of a disease or a condition of interest or to identify individual with a subtype of the disease. The classical example of this diagnostic biomarker is glucose, which ADA has given the cutoff value, HbA1c again this. So that is the diagnostic biomarker. Monitoring biomarker is a biomarker which measures repeatedly for assessing the status of the disease or medical condition for evidence of exposure or a medical product or a environment agent. So PT-INR used when patient has having this warfarin effect. That is classical example, age-old example of the monitoring biomarker. The response biomarker is a biomarker used to show the biological response potentially beneficial or harmful has occurred in an individual who has been exposed to medical product or an environment agent. That is again, as I told you, divided by into two, PD and the surrogate endpoint biomarker. When INR used as a pharmacodynamic biomarker, when it is used for the prevention of thrombosis event in a patient with the warfarin treatment, that is the PD marker. It's a definition, I'll skip it. And surrogate endpoint is the endpoint biomarker which used as a substitute for the direct measure or direct evidence of how patient feels, functions and survives. Classical example is HbA1c reduction in case of the complications associated with the diabetes mellitus, used as the surrogate endpoint biomarker. The predictive biomarker is used to identify individuals who are more likely than similar individuals with the biomarker to experience a favorable or unfavorable effect from exposure to a medical product or environment agent. So CTFR mutations, that is the example of a predictive biomarker in evaluation of the treatment of cystic fibrosis, where some of the treatment which has been given to a selective patient. Many companies are working with the companion diagnostic as they are offering, probably Roche is the company which is offering the molecule along with the testing. So that could be the prognostic biomarker which we are discussing is the biomarker used to identify likelihood of clinical event, disease recurrence or progression in patient who have the disease or medical condition of interest. So CRP is a prognostic biomarker which is identify patient with the unstable angina or history of acute MI with a greater likelihood of recurrent of coronary artery disease or event. Gleason score is another example of the prognostic biomarker in case of prostatic carcinoma. Safety biomarker is a biomarker that is measured for after the exposure or of medical product or environment agent to indicate the likelihood of presence or extent of the toxicity as an adverse effect. When we see see the nephrotoxicity or the liver toxicity, creatinine or ALT, AST are the examples of the safety biomarkers. Susceptibility or risk biomarker is a biomarker that indicates the potential for developing of a disease or medical condition in individual who does not currently have clinical apparent disease or medical condition. So CRP or HS-CRP used as a susceptibility or risk biomarker to identify adult patients with a greater likelihood of incidence of coronary heart disease. So this is actually the data of WHO. Which is from 2000 to 2020, and here if you can see that the percentage of causes of specific death in control total death, which is gradually decreasing throughout the years. This is taken from the fact sheet of the WHO, which it is available on the WHO website. So we, the pharma companies are understanding, or we, the scientists, are understanding more and more the mechanisms or pathophysiology of the this atherosclerosis and vascular disease, where they are using the development of drug, and because of that only, the reduction of percentage of death due to cardiovascular disease is decreasing over the period of years. So this is few of the biomarkers of cardiac disease, and this is the few of the biomarkers of the atherosclerosis. As per estimation, almost 200 biomarkers are right now with the few of the one or another pharma company has given for the drug development that is relevant with the cardiovascular or atherosclerosis biomarker. It is actually FDA data. I am going to skip the mechanism of atherosclerosis where the vascular endothelial cell and all this stuff. This is again few of the biomarker with the mechanism of atherosclerosis. CRP again, I mean skipping this thing. The one point which I wanted to highlight is the baseline CRP concentration in part is genetically regulated. That is very well established in 2004. So when we interpret this as a single independent cardiovascular risk marker, it is very important to see that what would be the baseline of that particular patient. So this is the structure of CRP. So it is a pentamer structure where each individual is connected with one another, and CRP has two binding sites. One is the phosphocholine binding site, which connect with the Fc fraction of the antibodies, and another is the calcium binding site, which activates the complement pathway. In that way, it activates the inflammatory response. I'm skipping this pathophysiology of how CRP, adipose tissue. This is something which probably I wanted to highlight, which probably not available somewhere everywhere. The change in the shape of the extracellular matrix, which is again associated with the CRP monomer, mCRP. So these are the papers. It's a meta-analysis which was done. This is probably the monomeric CRP. People are working on that. Here they have given the hypothesis of that. Here they have given the confirmation. Since probably 2012, there is antibodies are available to develop the ELISA kits. So this is again how the CRP, pentamer CRP, which converted or degraded into the monomer CRP, and it causes this kind of effects in the bloodstream and as well as in the tissue. So these are few of the data which were present with the analysis of mCRP. Mostly ELISA, but one assay which you can see that the cytometric bead assay. So someone in 2022 has developed flow cytometric analysis of mCRP also. So why this mCRP has lot of buzz? We'll see in the next slide, but this is again the, as I told you that this is for the inflammation and with the high sensitivity. This is the cardiovascular marker, essentially the same reagents, but the high sensitivity kits. Traceability should be again CRM at 70 whenever you are using. These are few of the data where you can see that the CRP is directly associated with the relative risk and the probability of cardiac free survival as your CRP is less than 1 is increases. Here there is a meta-analysis which was done. You can see that HS-CRP and homocysteine. This was done way back in 2000. So we are dealing with actually 70, 80 years old parameters right now. So you can see that these are the parameters which are directly associated with the CRP cardiac event. This is the few of the meta-analysis with the number of patients where you can find that CRP is associated with acute coronary event in patient with unstable angina. Post-MI CRP correlates with infarct size. CRP predicts coronary event in patient with unstable angina. So these are in symptomatic patient, and in asymptomatic patient also CRP or HS-CRP is directly correlated with the cardiac event or peripheral arterial disease also. This paper indicates that it is an independent predictor of peripheral arterial disease. Now this is something which was published in 2014. Dr. Paul Ridker has done a lot of work for CRP pathways, multiple metabolism in atherosclerosis, etc. So these are few of the mechanisms where upstream target for the biomarkers and these are the downstream targets for the biomarkers, where these are the pathways where pharma companies are working to block this, and enhance this. In that way, the molecule has been developed. So if at all you get the approval for that particular molecule, na, so that becomes the pharmacodynamic marker of for that particular molecular for CVD, that is MCRP or CRP. Again, this is one of the paper where the study has been done, the trial has been done for graft rejection in the renal transplant patient. So if you can see that they have tried to block this and this, because pentamer CRP is converted into this attenuated, or you can say the PCRP, activated PCRP, and then it is disintegrate into the MCRP. So they are trying to block these two pathways. Further detail of this, again, time's up. So anyway, so we are coming back from the first slide to last slide. The CRP is same as HS-CRP, but it is not same as MCRP because the antibodies are different, diagnosis is different. Analytical method must have traceability of CRM 470. It has already been established as prognostic, susceptibility, risk marker or predictive marker in association with other markers, and future possibility of PD marker. I'll skip that and we'll skip the homocysteine. So, I mean, basically I am associated with the basic research and we are working on this few of the pathways. I can show this on this molecule. So, on this pathway. So, this is something which probably I thought I should tell the things which are not available in the kit inserts. I think the clap is for the completion of the session or gala dinner, for the gala dinner.
Any questions? Because it was a very good presentation. Yeah.
Sir.
Previously, CRP and HS-CRP were been doing different platforms. You needed nephrometry or something to do HS-CRP. Now
Correct.
both are available on the same platform,
Correct.
same reagents, just
Correct.
the dilution factor and serum volume being adjusted
Correct.
in the Can we shouldn't be do away with the names and use single terminology to avoid confusion?
So, if you can see all the paper, na, so they are using the single terminology only.
Okay.
So, it is for the Mindray people.
Yeah, yeah.
to get the incentive on HS. So the costing would be different for CRP and HS-CRP. So if you can anyways get the high sensitivity reagent for CRP, you can very well use it. Because what is happening that the HS-CRP has the cutoff is as you say that 1.5, 2, less than 1, 1.5, 3. And CRP has, as an inflammatory marker, it is 6.
Yeah.
When you use HS-CRP kit for CRP values, a high value would you would result in doing multiple dilutions to arrive at a higher value.
No, ma'am, the thing is that when you have a CRP kit, na, so what you need to do, you need to increase the sensitivity of CRP kit.
Yeah,
And the lowest limit of detection, you need to go beyond that.
correct.
So if you have that kit, it is not the matter of the how high it is.
Exactly. So when you are interested on the lower portions,
Correct.
then you
So
use
in case
this
of
high
HS-CRP,
sensitivity,
yes.
but when you increase the sensitivity of a kit, there is a compromise on the the high, the upper end of detection.
Why?
Yes, HS-CRP has a limit only up to 12 or 12.5, beyond which once again you have to dilute and keep repeating the assay to
No,
arrive
but
at
see,
a final value.
if you have anyways more than 10 HS-CRP, na, you can use CRP kit.
That is what I'm saying. So you need to have 2 kits.
So, any more questions? Or we conclude for the day? So we conclude for the day and come back. Yeah. So we conclude for the day and we come back in an hour's time, and you know the theme and all. Okay. So may I request Dr. Dilip Ghosh Dastidar to please hand over the certificate to Dr. Kalpesh Gandhi, please. Dada ko bula, dada.